Anesthesia inductions, I just think is a really, really important topic. So with these inductions, the problem I find is that these happen really, not commonly at all. They happen rarely. And each consultant often has a different opinion about these particular inductions. And it's really difficult to make sense of all the complexities as a training anaesthetist. So, most of the time you'll go into theatre, you'll give some fentanyl, alfentanil, some propofol and a muscle relaxant and put the tube in. And then every now and again, you'll just get this really tricky induction. So really, I want to show you what those inductions are. There's a very select few critical general anesthesia inductions that are cardiovascularly and respiratory relevant. And if you just go through your training program, you'll stumble upon them every now and again. You'll get a bit of a lesson here, a bit of a lesson there, but it just won't be, you won't have it all in one bundle. And that's what I try to do with a lot of my ABCs of anesthesia stuff. Just put it in a bundle so you can, picture all of them comparatively. And that way you can hopefully, go further and understand it. I want to give you a framework that's pretty robust that most people will understand in the Australian anesthesia context, but probably worldwide. And this framework allows you to be practical and effective, and also what your consultants really want to know is specific doses about things. So I want to get to that practical level with this as well. And then, yeah, as we do in ABCs of Anesthesia, drill these techniques. So I'm going to ask you questions. You're going to be writing things down. If you have someone with you, share your thoughts with them and try to come up with some answers. So here are all your, the big players in your cardiovascular general anesthetic inductions. So the critical cardiac, hypovolemic shock, pulmonary hypertension, subarachnoid bleed, tamponade, valves, and HOCM, or hypertrophic obstructive cardiomyopathy. Hey, just to get the ball rolling, has anyone had one of these recently that they've been a part of? And that's absolutely fine if you haven't. Thank God for your patience, right?
So I guess maybe I would just say, so I wasn't involved in the intubation, but having just come off a trauma rotation, I certainly did see a number of severely hypovolemic shocks. So patients who had come in with severe hemorrhage and were receiving, like a massive transfusion protocol. So I witnessed a couple of them. I wasn't participating in the RSI, but I was in the room doing other things. So I've kind of tangentially seen and observed them, but I'd certainly love to know exactly what they were considering and doing at that time.
Yeah, good. And the good thing about that is once you've heard these terms, it's like one of those things where as soon as you heard the term, suddenly you'll hear the anaesthetist talking about them and picking it up. And then you might even see some disputes. You might see them talking about something differently to what I've said. And hopefully I'm going to justify why I think this way is the correct way. There's many, many ways of doing things. And you'll see that with anesthesia that, the amount of propofol, the choice of opioid may be different, but as long as you target these particular goals or the destination, the progress to that destination, the journey can be different as long as the goal is the same. So that's, definitely part of what this is going to be about. There's many different ways to skin a cat, many different ways to give a general anesthetic, but as long as your goals are similar, you'll be all right. So the cardiovascular framework, hey, does anyone have a cardiovascular system framework for, let's say something goes wrong with your blood pressure or your, something in your cardiovascular system? I got someone saying.
One way to think about it, maybe.
Yeah, go for it.
So you could break it down to a cardiogenic, hypovolemic, distributive, and obstructive causes as well, which could cause your hypovolemia, your hypertension.
Yep, that's perfect. So there's these two common ones that people talk about, which is your rate, so your preload, rate, rhythm, contractility, afterload, but then also your shock definitions, which broadly fill these criteria. I happen to use this one just because it clearly mentions your rate and rhythm as well. But I absolutely agree, cardiogenic, obstructive, distributive, hypovolemic, shock classification are really useful for this as well. Stefan, just while you're there, do you have definitions for these. Have you heard these terms before?
Yeah. So the preload is essentially like the volume that's going into your right atria from the systemic circulation. Rates is essentially just the number that the heart's beating at. Rhythm is just like, whether it's sinus or a non-sinus rhythm. And contractility is generally like, the force of contraction. So
that's right.
Like the inotropy force of the heart. And afterload is essentially like your systemic hypertension. So the pressure that the heart is pumping against.
Beautiful. And I like the fact that you just gave short, simple definitions that were easy to understand. Like there's some really serious technicalities with this, but yeah, preload, the force that stretches the cardiac muscle prior to contraction. But really, when you think about it in practical sense, it's your venous return or your filling of the heart. So your volume status often reflects your preload rate. What we're going to do is, like, no one wants a super high or a super low heart rate. So often they talk about low normal, high normal, or normal. And we'll definitely go through that. You're absolutely right about, it's really either sinus rhythm or abnormal rhythms, and you definitely don't want abnormal rhythms. So in this context, you're kind of trying to decide, is sinus rhythm critical or not? And that comes a lot in the valve lesions as well. Contractility, force of contraction of the heart muscle, and then afterload is the force that impedes or opposes ventricular contraction. And often that is systemic hypertension, but it also can be having a aortic stenotic valve as well. So let's get started. Let's get right into it. Now, I'm very deliberately giving you an age of a patient and a weight. That way you can consider the dose. In our final exam, the examiners never want to hear you say mics per kilo in general. They just want you to give a dose. And that way it's, just it's a very practical exam. And I think that's how most supervisors in anesthesia in Australia would be practicing. So deliberately I've given you an age and a weight. And I'm not giving you much else except the condition. I want to keep this really simple in terms of this is the pathology and this is what we're targeting. And so how would you do an induction for a general anesthesia for a 60-year-old male, 70 kilos, with just an ischemic cardiomyopathy with ejection fraction 15%? So I want you guys to take a few minutes and just write down what you think you'll give for this induction and how you'd give the induction. And I might ask, so this is where I'll just, ask someone, and I'll mention them first off. So I might ask Calvin Fletcher, take a minute or two and just come up with your induction. And everyone else, obviously, write down your answers as well, commit to your priorities, and then the actual doses. And if I didn't mention before, your priorities, you can often frame in terms of preload, rate, rhythm, contractility, afterload, and other things if you see that they're relevant. It's about 90 seconds there. Calvin, what do you reckon? What are your priorities first? And then we'll go with the actual doses.
Yeah, great. So I think if we've got this man with ischemic cardiomyopathy, in terms of preload, rate, rhythm, contractility, and afterload, I think we'd want fairly normal preload. You'd want sinus rhythm ideally. And I think you'd be focusing a bit more on those cardiac factors for this patient who's got this ejection fraction of 15%. So I think that you'd be wanting to make sure that you've got a cardio stable induction, and you're not getting the patient too tachycardic or anything like that during induction. So you probably want a bit more opioid and all that thinking forwards. In terms of afterload, this person has ischemic cardiomyopathy, so they've probably got reasonably critical coronary arteries, and probably needs a bit of afterload to be able to get some perfusion going as well. So those are the things I'm thinking for this patient initially.
That's great. So let's say on that point of afterload, so you've essentially said keep things preload normal, contractility you're going to be a bit worried about, so probably keep it normal. Heart rate normal, I think you mentioned.
Yep.
Rhythm, sinus rhythm, obviously you'd like that, but often these patients are in atrial fibrillation anyway.
Yeah.
And then finally afterload. Let's say this patient comes to you at a blood pressure of 140. What would you aim blood pressure during induction, or what are your parameters for induction?
And it's a good question. I think they come to at a blood pressure of 140. You wouldn't. I don't remember the specifics off the top of my head, but I think a ballpark range. I wouldn't want them to drop much lower than systolic of 120, 110, because their baseline is already hypertensive in that case.
Yeah, good. And so often a patient comes to me with some, bad disease, whatever their blood pressure is now, and they're surviving. I try to keep it at that, because that's obviously what the heart is tolerating and the body is kind of supporting. So that's just one rule I'd have for this. Yep. So that's good. Everything normal, but support normality, whatever that normality means. But what are your doses or style of induction for this cardiac patient?
Yeah. So I think, as I understand it, propofol can be a cardiodepressant. So we'd have to make sure that we're pretty low on the doses of propofol, and perhaps we're using a bit more fentanyl, a bit more opioid to be able to get through, to also to dull the sympathetic response and get a more normal heart rate. So I think what I'd probably do is maybe give a very small dose of propofol, 25 to 50, give fentanyl at quite a large dose, maybe 350 in this case. And I think I remember Midaz is a bit more cardio stable, so maybe giving 5 milligrams of Midaz on top of that, as well as if we need relaxant, I think maybe rocuronium at 50 milligrams would be fine here, and I think that would be a reasonably cardio stable induction.
Yeah, good. Now that's really good. And so I like the fact that you said propofol just a little bit, because it can be very cardiovascularly depressant and vasodilatory. And I was going to ask you at that point, well, if propofol is dangerous, then what can you use? And midazolam is absolutely right. So, when I'm doing these patients often come for CAGs or some kind of LVAD or some kind of weird sternotomy case, so that you're in cardiac theater, it's going to be a long operation and you have to put a lot of lines in. So the pattern of what happens is usually you've got the patient there, Hudson mask on, so they're ventilating normally. You give it 50 of fentanyl, a bit of Midaz, put some lines in, and then you give a bit more for the bigger lines maybe. And by the time you're about to do the induction, they've probably had a good 5 milligrams, 3 to 5 milligrams of midazolam. And they've, like you said, they have had a big dose. So you might have given 100 of fentanyl as you're putting lines in, and then another 200 induction. So anywhere from 300 to 500 of fentanyl could be done in that first phase. And then know that midazolam and fentanyl will often be enough to get this patient asleep. And often at that point, you're running like a small trickle of propofol. So yeah, 10, 20 mils maybe. Now that isn't all that happens. You mentioned 50 milligrams of rocuronium, and that's a normal dose, and you won't run into too many problems. But because I really want to get good conditions straight away, and the operation is long, there's really little harm from just giving the full 100 milligrams of rocuronium or a big dose of rocuronium. That's at 50 milligrams is not the wrong answer at all. Plenty of people would give that, I'm sure. And then what you see is, so the next thing I'm going to ask you, so all of that I completely agree with. What are you expecting to happen as you do this in the sickest patient? And what things are you going to do to fix those problems that you're going to have?
So I'd probably expect that the blood pressure would drop a little bit, and I think I would want to make sure that I've got some vasopressors on hand. Probably, I think in this patient, metaraminol would be fine. I wouldn't be going for something inotropic just because I've got the heart failure in this case, though I may be wrong on that.
Yeah, so good. So you expect the blood pressure to drop, so you'll be having metaraminol in the syringe on an infusion line, and as soon as you might have it started running at 2 2 milligrams an hour or something. And then as soon as the blood pressure starts dropping, as you're slowly going up with the sevoflurane, then you might increase as well. So what you notice with these inductions is it's a very slow, it doesn't have to be a rapid induction. I'm giving 100 of rock, not to do a rapid sequence, but I'm doing it because I just want really good ventilating conditions, and a paralyzed patient is always easier to ventilate than an unparalyzed patient. So again, imagine this system. I've given all my induction drugs, the patient's asleep with minimal of anything. Then I start bag masking, waiting for the muscle relaxant to work. I'm slowly going up on the sevoflurane, like tiny amounts. So, and if you've been in anesthesia, I'll just let you know this, but say 6 liters of flow, maybe 1% of sevo, let that MAC rise to 0.3. And then you've got the biz on, so you'll know roughly when they hit less than 60 on the biz, so you know they're asleep, and you take all the time in the world. As you're doing that very slow induction, then you'll notice that the blood pressure drops, so you turn up your metaraminol. Because it is cardiomyopathy, that's where I'd slightly disagree, and I'd have ephedrine ready, because ephedrine now has the inotropy, whereas metaraminol has the vasoconstricting potential. And that way I'm slowly promoting a bit of inotropy in this as well as vasoconstriction. So those are all the things that I'd have ready, because that's what I expect to happen with this induction.
Lahira, just for that one, just so for my understanding, because you mentioned you would want some inotropy. I think I may have been thinking of ischemic heart disease. Is that where you don't want to stress the heart too much with ephedrine and inotropes rather than heart failure? But that makes sense in general terms.
Oh yeah, absolutely. I've been pretty vague on this. So let's say, I like that you pointed out the subtlety. If this ischemic cardiomyopathy, let's say the heart attack happened and it's, they've had the stent and they've had whatever intervention and they've still got a cardiomyopathy with patent vessels, great. But if they, have a really tight coronary, you definitely don't want to stress the heart too much. So this is where, you're not giving huge doses of, ephedrine or anything. It's just to promote, like, this ejection fraction so low that you just need to give it something. So that's why you'd use ephedrine rather than adrenaline. And then, you're not trying to aim at some ridiculous amount of inotropy or ridiculous amount of chronotropy. So that's where this balance occurs, and you're not, you could never really know where the optimal range is, but I know that a bit is probably what it needs. That's a really good point. Hey, so any questions about that critical cardiac? Because this is the one that, this is probably the one that scares most people, the most, because the heart is failing, whereas a lot of the other ones, the heart is fine, and there's other factors that are in play. Any questions, or did anyone have any different approach to this?
Can you hear me, Lahira?
Yeah, go for it.
This is Jason Verdon. Probably putting it out early, a contentious one. What are your thoughts about ketamine? I've worked with quite a few different consultants. A lot of them shy away because they're thinking its sympathomimetic effects would just promote ischemia. However, you don't have to be all or none. So I'm wondering if, dividing your doses between propofol and some ketamine to actually reach a nice balance in terms of your hypnotic and also preserving the inotropy.
Yeah, if you target the goals of normal preload, normal rate, sinus rhythm, preserving contractility and afterflow, ketamine is absolutely perfect for this. The reason, I'm not sure exactly the reason we don't see it. I think it's because, you're giving so little, if any, of your propofol anyway. Midazolam has very little effect on inotropy, whereas ketamine is a direct inotropic or negative inotrope, even though it's an indirect positive inotrope. And so I think that's probably why ketamine isn't used as much when I've seen it done in cardiac centers. That said, if you just, I'm giving so little of all these drugs anyway, even if you were just to give it a little bit of ketamine as a kind of a multimodal approach, I just don't see any problem with it. I've just never seen the, really big advantage of it over this other system. That said, you could totally do it that way. And there's no ramification of using the ketamine and then having to wake the patient up quickly. This case is going to probably go on for a bit longer.
Yeah, the scenario I was putting myself in is if I didn't have the luxury of being in a cardiac. So let's say I've got this old person who has had a misadventure. Let's say they have to have a NOF or, some other thing. So I've got to just do my general anesthesia. I'm not going to be putting them on bypass or anything like that. So how would I keep a cardiac stable? But also, as you said, be mindful that if I bomb 500 of fentanyl into them, they're not going to wake up at a reasonable time for whatever surgery I've given. So I'm thinking laterally in terms of the context you might actually encounter them in your clinical world.
Yeah. Hey, that's a really good point. Like, say I've given this 5 mics per kilo of fentanyl in the context of a long case, cardiac surgery. If I had a shorter case, I would absolutely use something shorter acting to get my analgesia at that really optimal effect, because I don't want a tachycardia and laryngoscopy. Again, I've never seen ketamine really prevent that. Like, it's not that much, it's not as an effective analgesic as fentanyl. But again, with the right mixture of a bit of ketamine, bit of fentanyl, I think you're absolutely right in saying that if it was a shorter case, you could combine those two to give less fentanyl. Or you might avoid ketamine and give some alfentanil and midaz and do something similar. You know your pharmacology of your drugs, therefore you can target your goals and priorities. Really, really great point, Jason. Like I love the fact you've raised that, because you can totally mix and match these medications and find the same goals, and then try to target the goals for the surgery and the other contexts that you're worrying about as well.
Thank you.
So let's go for the next one. Hypovolemic shock patients.
Follow-up question on the you go, Rose.
I just had a question in terms of avoiding the sympathetic surge with instrumentation of the airway. Would you think of something like esmolol, or do you worry that you'll then drop the heart rate too much, or that there's a risk of in a patient that might have heart failure? I've just seen esmolol used sometimes just in regular non-cardiac inductions as actually instead of opioids to avoid that surge.
Yeah, now was that a opioid-free anesthesia technique? They were trying to minimize all opioids. Was that situation, or?
That particular consultant will use opioids later on,
okay,
but their preference is now at induction to just use esmolol.
Yeah, okay, that would be probably on the outside the normal distribution of what most anesthetists do. So I'd say that's a bit outside. Again, you're targeting endpoints. It could be completely reasonable. I think most people in anesthesia, like if you were to say that for your answer, it'd be more of a speculative thing. Like I wouldn't go first up with that, because it's outside of what most people do. And most people just go, look, you're going to get pain, just give fentanyl. Again, there's a new trend of opioid-free anesthesia that's kind of out there. And if you're trying to give no opioids, people would use esmolol, and that's trying to target the fact that opioids do have certain, addictive problems as well as hyperalgesic problems later, and it has all these bad effects. And they're trying to just create, what are the surgeries we can just avoid all opioids for? So I've seen it in that context, but that's definitely not what you'd be wanting to talk about in your, if you're starting your first or couple of years of anesthesia. But yeah, really good point.
So the hero, just a follow-up question on the discussion that you had in answering Jason's question. If you were to use something like alfentanil instead of fentanyl, what would the dose be like for this critical cardiac situation? I've typically seen 1,000 micrograms for just normal standard patients. Would you need to use more for a cardiac
That's a really
induction?
Good question. The reason we seem to give fentanyl, I think, is they call it cardiostable, but I think it's because it's just got a slower rise up to a maximum efficacy. So, you've got time to give a bit of aramine, and sort out problems. Alfentanil is a very rapid acting drug. And so if it's that rapid acting and this patient has very minimal reserve, then I've just got less time to sort things out. So if I was to use alfentanil, I agree that I'd probably want to get to around 1,000 micrograms, roughly 10 to 20 mics per kilo for a good effective analgesia level. but I probably want to get there slower so that I have time, I have time to sort out the problems that it could cause. So what I would do in this patient, 60 kilos, bad heart, 70 kilos, sorry, 60 years old, bad heart, 70 kilos, I'd probably give, 200 mics to start with and just see how they're going, and just keep incrementally bolstering that every couple of minutes during the induction, something like that. And then you might ask, how do I know when it's working? You'll probably start to see a bit of a bradycardia occurring. That's kind of when you know your propofol and your volatile and your fentanyl, your opioids are all hitting, and the patient's now really obtunded from the anesthetic. At that point, I'd probably start, giving a bit of ephedrine and running the aramine as well. So alfentanil, not as elegant as using fentanyl. There's a few more things to do. You've got less room for error. Just like remifentanil. Remifentanil is super fast, super effective, and there's far more instances of severe bradycardias with remifentanil and this chest wall rigidity thing that happens as well. So really effective, but then in patients with minimal reserve, who I don't have too much time to sort out problems, I far prefer fentanyl, or I'd use the other ones in very small titrated doses.
Awesome, thanks.
Yeah, good question. Hey, and by the way, so I've got all the time for these questions. So these are the kind of things I really want you guys to ask, because when you're starting out, there's just so many little nuances that are worth talking about. So I'm really glad you asked those questions. Okay, hypovolemic shock, 21-year-old male, 70 kilos, motor vehicle accident. And so just imagine this patient's come in and they've probably got 3 liters blood loss. So they're tachycardic at 130, hypotensive at a BP of 80. Now, everyone write down your priorities. And at the end of that, I might ask Zuchi. So take a couple of minutes, write down your priorities, and then the actual doses for this patient. Let's say they're having a laparotomy for some kind of intra-abdominal vessel rupture. A 90-second, what do you reckon? Your priority.
Sorry, are you asking me? It's a bit quiet over you. Sorry.
Yeah, yeah. I was asking for, what are your priorities?
So I feel like in this patient, so I think the priority would probably be the preload is probably going to be the most significant issues, given that he's got so much bleeding going on. So I guess it'll be important to know what the current blood pressure is and what has been done to fill up the preload, like what kind of fluid resource has been given, or there's blood running at the same time. So try to aim for a normal preload. I guess like pretty much like normal gray, like green, reason rise, like I would imagine for a 21-year-old, hopefully it would be fine as reason. And normal contractility and normal afterload. Yeah.
Good. Okay, so I agree that when in the context, there's going to be a lot of volume loss. So you want to support your preload, and these patients have low blood pressure, so I'm going to be supporting that after, and everything else is probably going to be like, so naturally these patients come in with a super high contractility because they've got sympathetic, increased sympathetic tone and everything. So I'd almost say that, you're okay with the fact that they've got a really high contractility, right? Because they're young and fit and well, whereas in the previous case, they got a bad heart. So just think about that now when you're offering your medications that you give. So for this patient, there'll probably be a rapid sequence induction. What drugs would you give for this?
I'm not very familiar with it, but I'm guessing you're still gonna give some sort of opioid to begin with. So I imagine it can probably be similar to last time. You can still do like fentanyl 100 to start with, 100 mic to begin with, and Modazolam.
Just to say that,
yeah.
If you haven't done too much anesthetics, it's completely fine. This is going to be your first time just verbalizing doses. It's completely fine. Just have a go, and we'll discuss it anyway.
Yeah. So yeah, thinking probably 100 mic of fentanyl, probably like Modazolam 3 to 5 milligrams. In terms of the propofol, look, I guess like because there's no significant heart issue, like obviously you don't have to go super low with how much you give, but you also don't want to give too much that you suddenly drop the blood pressure too much. But also I'm just bearing in mind that in this kind of context, when you have like abdominal bleeding, you also try to do like permissive hypotension, like as long as the sleep blood pressure is just around 90 or something, and that is tolerable. Yeah, so I'm really not sure about the propofols. I'm guessing somewhere like 70 or 80 milligrams.
Good. And what relaxant are you going to give and how much?
So like you say, it's RSI. So I'm guessing it's like, my guess is like 100 milligram rocuronium, or you go for succinylphonium.
Perfect. Okay, so let's talk about those things that you mentioned, because a lot of what you said was absolutely true. So your goal, I just want to really avoid significant decrease in preload and afterload. And so what I'm saying there is I expect that this patient has no volume in the venous side, and the arterial side is going to be challenged as well. Therefore, that's why I need support. The rest of the stuff there, I don't care about too much. I don't need to moderate the contractility, because young, fit patient, sympathetic stimulator, I want that because that's what's supporting a failing cardiovascular system. When you've got preload, rate, rhythm, contractility, afterload, a decrease in one often necessitates an increase in the other things to help promote it. So imagine patient with low volume, to get the cardiac output to go to your brain and your other important organs, you need an increased heart rate, you need better contractility, you need to increase your afterload. So yeah, when you start learning about the left ventricular flow volume curves, the way you compensate for failures in one of these indicators of performance, like low afterload, low preload, is to increase the other ones. So good. So in this situation, I'm just targeting preload and afterload because that's what I care about in this situation. Now, I've just said an RSI with ketamine, midas, succinylphonium, and with, again, because I know that my problem here is going to be vasodilation, venodilation, and a lack of volume there. I'm not really too concerned about having ephedrine ready, because this is a young patient who's got super good contractility. So really metaraminol is my vasopressor of choice. Now you notice that I didn't really, giving 100 of fentanyl, it's very common. I totally give that, but I don't really care about, sympathetic stimulation during laryngoscopy. I want that to happen. I need this patient's cardiovascular system to be supported. The one thing I'd pick up on, and this is a great learning point, propofol is so cardiovascularly, it creates such potent vasodilation and venodilation that if I was to give propofol, it'd be in the realm of, less than 5 mils. So, 1-2 mils, something like that would be plenty if I was giving it. But these patients are so obtunded that just giving some, let's say you did that induction. If I gave 100 of fentanyl, and I just gave 3 mils of propofol, that would probably be enough for this patient. Just to make sure that they don't have awareness, I'd just give a big dose of midaz as well. It's just so cardiostable, and it'll probably just hit them like a ton of bricks anyway. Succinylmethane or rocuronium, doesn't matter. Just give a proper dose to get intubation conditions quickly for an unfasted patient. And I know my blood pressure is going to drop, therefore I'm going to run metaraminol and give boluses as well. Yeah, so the midaz, literally, I'm just giving midaz because I'm going to, I need a hypnotic. You know, maybe I often don't give that much ketamine in this situation. So in this patient, I might just give 40 or 50. I've still seen massive blood pressure drops with ketamine because it's a direct negative inotrope. And the indirect positive inotropy of ketamine will have minimal effect because this patient already has a supercharged sympathetic system. So I'm giving midaz as a bit of a co-induction. It's, you know, if I was to give it, there's just little harm from me giving a full 5 milligrams. I have more reassurance that they'll be asleep when I put that laryngoscope in, because I'm going to be tending towards giving less hypnotic agents, less ketamine, less propofol. Midaz is just my safety margin. Any questions or any deviations from that for anyone?
Hey, Lahira, I just had a quick question about your vasopressors. At what point do you sort of transition between metaraminol to, say, noradrenaline, something a bit stronger?
Yeah, if this patient had a central line in, I would definitely be starting noradrenaline. In the context of a patient who's come from a, you know, let's say, I'm not sure if I've given the context, but yeah, it's a motor vehicle accident, 3 liters blood loss. They'll never have got a central line by the time they get to theatre. So that's a great question, because the context is the patient rushes in, they've got lots of volume loss, they'll be starting a massive transfusion and getting everything sorted, but really the remedy is getting them to theatre. I'd almost say if you've taken the time to put a central line in, you've prevented faster access to theatre and the surgeon clamping a vessel, and that's pretty much why. My opinion is, if they've been managed correctly, they won't have a central line because they should have gone to theatre in that time and put the central line in. Yeah, that's
beautiful. Thanks.
Hi, Lahiru.
Yeah.
Yeah, I just wanted to ask you, so do you think that we need to put the arterial line before the induction because there are going to be so much hemodynamic instability? So do we need to have that beat-to-beat blood pressure monitoring during induction during this case?
Yeah, sorry, and I haven't mentioned that, but absolutely all of these cases will have an arterial line as minimum.
All right.
And that's a good point, because I haven't mentioned the setup for this. I've just mentioned the goals and the induction, but absolutely most of these cases will have arterial lines, and some of them will have central lines based on the context. Like the previous one may have a central line on induction for sure.
Right. Yeah.
And a few others as well. Yeah, good point. Any other variations? So there's a lot of variations to this. You'll see plenty of people giving, you know, a couple hundred of fentanyl and giving, you know, a small dose of propofol. So 100 of fentanyl, 200 of fentanyl, 5 mils of propofol, 3 mils of propofol, rocuronium with metaraminol running. That's totally a thing as well. Yeah, just know there's a lot of variation for this, but our goals and our endpoints are all the same. I consider this case pulmonary hypertension, say 50-year-old female with pulmonary fibrosis, severe pulmonary hypertension, let's say, you know, MAPS, you know, mean pulmonary artery pressures of 70, 80, something crazy like that, you know, 50 kilos. Think about your priorities and think about your actual induction style. And I might ask Nick Angelopoulos. So take about 90 seconds.
Ready whenever everyone's ready.
Let's get started. It's about 90 seconds. And also just so quickly, if anyone needs more time to have, go writing stuff down, probably just let me know. Completely fine. Go for it.
Nice. So I guess in terms of priorities with this case, we've got someone with pulmonary hypertension. So the main thing we're worried about is the pulmonary pressure. So I guess we'd consider that afterload. So thinking about my preload, I want to maintain my preload. So we've got good cardiac output. I want to have a good rate. I don't want to be too high or too low. So aiming for a normal rate. Want to obviously have sinus rhythm. So yeah, in terms of our...
And actually, what did you mean by afterload in this case?
In this case, I'm talking about the pulmonary pressure, so the force in which the right heart has to pump against to get blood volume out.
Beautiful. So I just want to raise that point. That's a really important distinction here. In your critical cardiac case, we're really just talking about the whole heart and left ventricle. But suddenly in this case, now I've got a really, really high potential afterload to the right heart. So I'm thinking about pulmonary pressures and optimization of that in one hand, and then right heart function on the other hand. So these are the two basic things: pulmonary pressures and right heart function. So how do you target that, Nick?
Yeah, so we want to prevent the right heart from decompensating. So in terms of doing that, we're less worried about having low blood pressure, and we're more worried about making sure that we optimize cardiac output. So what I want in this case is I'd go for something that would use fentanyl, and I'd use a higher to normal dose, so maybe about 200 mics for my induction. In terms of, I'd be using some propofol, so that's how I differ from the other cardiac cases, because I'm not too worried about being a little bit low in terms of the blood pressure, because the problem is afterload here. So maybe given this person's only 50 kilos, maybe 50 to 70 megs of propofol. And in terms of my agent for my muscle relaxant, I'd be using either 100 of rock or 100 of succinylmethonium. And to add on to that, I guess what I'm going to make sure is I've got, really good pre-oxygenation, make sure they've got maintaining good ventilation. Don't want to use pressures that are too high because that may increase the pulmonary pressures and lead to decompensation. So that's my approach there.
Yeah, beautiful. So what are the factors, and you're addressing these, what are the factors that will increase my pulmonary vascular resistance? And you mentioned hypoxia.
So high CO2, high pressures. So if you're ventilating with high pressures, you'll end up causing you'd have like a pressure effect on the arterioles on the arteries within the pulmonary vasculature. And yeah.
That's perfect. So my goal is to avoid increase in pulmonary artery pressure. So that really is exactly what you said. I need good oxygenation. I need normal CO2. Definitely don't want that to increase to a high amount. Normal pH is usually consistent with your CO2 in this context, in an elective type situation. I want to avoid high ventilated pressures, and I want to avoid, too many vasoconstricting drugs. And then I talk about right heart perfusion, which is really, essentially your critical cardiac for your right heart plus pulmonary artery stuff. So, decent preload, normal rate, sinus rhythm is probably critical in this patient. And I talk about a decent afterload just because I want it normal to give good coronary perfusion to the right coronary artery and the right heart system. So when I think about that, think about this practically. The drugs you said were absolutely right. So you've noticed this pattern that most of the time you want to give high-dose rocuronium or succinylmethonium or whatever, because I just want to get a paralyzed patient quickly, whether I'm going to put the tube in or not. So in this patient, again, I do this, as a nice gentle induction. I'm watching all my pressures. I'm making sure that I can ventilate. I want them paralyzed straight away because an unparalyzed patient might fight my trying to ventilate them, therefore increasing lung pressures. And if I can't ventilate, the CO2 rises and that causes the pulmonary artery pressures to go up. And if I can't ventilate, oxygenation goes down again, my pulmonary artery pressures goes up. So all of having really good airway management for these cases is absolutely paramount.
Sorry, Lahiri, you've just cut out.
Lahiri, your mic is cut out. Your video is still going all right, but the mic's a bit quiet at the moment.
All right. Okay. Just switch that now.
That's better.
Hey, can you hear me now?
Yep. This is the best I've been able to hear you.
Ah, I think I had a faulty mic. That's probably why. Okay, good. So what I was saying was, yeah, essentially think about the situation. I'm putting a lot of effort into ventilating this patient really in a stable fashion. They're paralyzed. I'm slowly just making sure that all the drugs are working. And if their blood pressure drops, then I run a bit of aramine to get a normal blood pressure. Everything happens very electively in this situation. So yeah, let's say you give 200 mics of fentanyl, maybe 50 of propofol, 100 of rocuronium, but I'm absolutely making sure my oxygenation and ventilation is perfect.
This might be a very specific question, but metaraminol, I know that it increases your afterload typically, and I know that's thinking about left heart, but does that also constrict the pulmonary artery as well? Like thinking about how we're trying to avoid afterload. I know ventilation is the main way that we do that, but is that an issue at all, or is that just a theoretical sort of thing?
No. So pretty much almost, my mate actually did the studies on the dose response curves for various agents and how it affects the vascular system. And I'm trying to recall which ones didn't. I'm gonna have to first say that I can't remember exactly which ones had the most effect on the pulmonary vascular system. So, whether you're giving noradrenaline and metaraminol, chances are it's going to cause a slight increase in your pulmonary artery pressures anyway. Now, even if let's say the problems of the hypotension are so bad that you'd still want to run your most familiar, most forgiving agent. So, metaraminol will have effects on the pulmonary artery system, but still you use it because it's what you're used to giving, and you're going to have a drop in your systemic pressures anyway. So I've done a few of these inductions of really severe pulmonary hypertensive patients, and it's quite interesting because the theoretical thing that you need to do in this is, chuck in a Swan-Ganz catheter or pulmonary artery catheter and measure the pulmonary artery pressures and maybe have an echo to see a function. But all of these things do complicate it. So imagine if you're not used to doing an induction with echo and pulmonary artery catheters in all the time, chances are you'll have, you're not used to doing something, so you'll potentially do it worse. Every time I've ever done these really difficult cases, I've had an art line and I've just done my normal style of induction with nothing else. And that's gone well. So there's just this principle of when it gets really complicated, sometimes you just have to keep it simple because the extra complexity causes problems. So yeah, it's a really good question, Calvin. I think most of our agents affect the pulmonary artery pressure, but so because you need to give something, you give the thing you're most familiar with giving. And is there a reason that you wouldn't give ephedrine here? And I might be missing something, but why wouldn't we give that over metaraminol? You could totally give ephedrine. Often ephedrine doesn't have, I really want to address the right heart perfusion. So I want to make sure that I've got my map at a decent level for the right heart. If I had any worries about my contractility, I'd have ephedrine ready as well. But yeah, good point. I'd totally have ephedrine ready and potentially give it if I had a falling blood pressure. So this is a good point. If I'm doing this induction and my blood pressure is falling, I'll start my metaraminol infusion. If it's not working, and this is for any situation, not just this, if my metaraminol is not working in spite of running a decent amount, giving boluses of it, just know that all you're addressing with metaraminol is preload and afterload. And if it's failing, it means that you've probably made a mistake on your assumption that the problem is preload and afterload. Therefore, I have the ephedrine ready and I give small doses because I'm thinking it's a contractility problem. And that I do in lots of circumstances where I've had patients who the blood pressure drops. I give a bit of metaraminol, and it's just not working the way it normally does. Just don't forget that in that situation, it could be a contractility issue. So then I give get the ephedrine out.
Here, I just have a couple of questions.
Yeah, go for it.
The first one is regarding what ventilatory pressures you would consider too high in someone like this. And the other question was, if this was a patient with mild or moderate pulmonary hypertension, how would the dosing differ for the drugs?
Yeah, and the first question, I'd give the lowest pressure that I could ventilate adequate tidal volumes in minute ventilation. And so when I'm doing the ventilation, I would just have the APL valve, that's a pressure limiting valve on your machine. I'd have it at 10 to 20. I just don't want to get spikes up above 20 really. That said, if my oxygen, this is where it gets tricky. If my oxygenation is getting low, maybe the patient is a large patient, I've got other complexities, I just have to slowly titrate up. But I do everything to make sure that I've got it as low as possible and it's satisfactory. So what does that mean? I put a Guedel in if necessary. I put an LMA in if necessary. I give big dose relaxant and I just alter the pressure with the valve, make sure that the valve is close to me so I'm able to do that quickly. In terms of if it's mild pulmonary hypertension, you know, I look at the patient's function and the context, but mild pulmonary hypertension with everything else fine. I think a lot of patients with OSA and, you know, obese patients probably have that. It doesn't affect my induction too much. Moderate, I'd treat a moderate hypertension just like this because I'm not sure, you know, that's just one reading on maybe a right heart catheterization or an echo some years ago. I'd treat a moderate pulmonary hypertension with the same caution I'd treat a severe one, just knowing that it's probably going to go better anyway. Yeah, really good question. So yeah, that's the practicality of it.
Thank you.
Hey, Jason, thanks for that. Thanks for that input there in the chat. The vasopressin actually has been shown to produce pulmonary vasodilation, but that's central line stuff. Yeah, I mean, there may come a time when I'm so used to giving vasopressin that, you know, you'd run it for this case, or maybe you're in an institution where that's the thing. But as soon as it's a really good theoretical point, and I can imagine in some centers they start using it, they get very good at it. That's what you do. Next case, so subarachnoid bleed, 50-year-old female, 80 kilos. It's a grade 3 subarachnoid hemorrhage for an early clipping. Yeah, so I might ask the next person along, which was Zheng. So Zheng, yeah, take about 90 seconds. Consider what your priorities are, and if there's any extra priorities to your preload rate rhythm contractility afterload, and then what exactly is your induction technique. Also take about 90 seconds. That's been 90 seconds. Zheng, what do you reckon?
Yeah, hi, Lahiri. I'd just like to preface, haven't previously done too much anesthetics before, so might be a bit rusty with all this dose of stuff. But I guess just falling back to first principles, patient with sacral hemorrhages, I guess the main thing to sort of keep in mind will be to sort of maintain the cerebral perfusion pressure, and also considering our ways to sort of reduce the cerebral sort of oxygen consumption, especially with the induction agents that we do use. And so in terms of sort of the preload and afterload, so
actually,
I think
I'm going to stop you saying, so the stuff you said just then, again, from first principles, even though if you haven't done too much anesthetics, that was actually pretty perfect. So during the case, you're worried about CPP and you're worried about cerebral oxygenation. Now, because it's a subarach bleed, there's one more thing. There's another thing that could happen that's the highest mortality event at any point in time. And I'm just going to get you to guess. What do you reckon that is? You had a subarachnoid bleed. The patient's now kind of stable-ish and they need to go for clipping. What's an event that could happen which would stuff everything up?
Yeah, so I'm aware. So separate hemorrhages, one of the complications would be potentially cerebral vascular like spasming from
and that's a
the
more
vasculature.
thing. Let's say that's a common thing, but you're absolutely right. Anything else that could happen to this vessel?
It can, or the vessel itself. So assume the vessel might have ruptured already from the subarach bleed.
Exactly. So it's done this.
Yeah.
It's ruptured, and now it's clotted off.
Okay, so potentially like secondary ischemic event from potential downstream clots, or
actually a secondary bleed. So it's
okay, yep.
It's one of those weird things, right? The subarachnoid bleed has happened, and it's all bad. It's stabilized, and now before they go to on induction, you do something, and then it rebleeds again. What do you reckon is going to cause that rebleed to occur?
Yeah, so I think potentially during the sort of the laryngoscope or whatever maneuvers that we do to the upper airways, we can produce a sympathetic surge that could cause the sudden increase in the mean arterial pressure to cause the additional oomph to make the secondary bleed occur.
That's good. And so the term they use for that is transmural pressure gradient. So transmural, so through the wall pressure gradient. So either your blood pressure spikes or your cranial pressure suddenly decreases. So in our context, you do laryngoscopy like you mentioned, and the patient's not obtunded enough, they're not analgesic enough, and suddenly you get a massive spike in your blood pressure that's uncontrolled, cause a rebleed. And the mortality of that one thing happening is 60%. So, subarachnoid bleed's bad enough, you cause a rebleed or rebleed happens because of a bad induction, boom, the patient, you're flipping a coin on the patient's life. So that's why this is really important. And it's exactly, you worked through that to get to that point, which is great. In the context of the whole of our operation, when they open the dura, that can suddenly decrease your intracranial pressure. Therefore, that can also cause a rebleed. But luckily at that point, the surgeons are in there. So there's worse outcomes if the brain, if they're not into the brain yet, rather than, like with induction. So tell me, knowing that, what do you reckon your induction is going to be like?
Yeah, so I haven't dealt with too much sort of the pharmacology side of things, but I'm aware that agent that I've seen used in sort of the trauma setting where traumatic brain bleeds would be thiopentone, something that has been seen used as a agent that does sort of reduce the cerebral oxygen consumption.
Yeah. Cool. So just to give you context, most people probably use propofol. If you use thiopentone to decrease your CMRO2, cerebral metabolic requirement of oxygen, CMROT, that's totally a thing. But often people just go with propofol because thiopentone is like the thing you might run in ICU if you suddenly get spikes in ICP and you're really trying to do everything you can. Now, let's target the thing that was going to cause the biggest mortality right there. What are you going to do with your induction to make sure you don't get a blood pressure spike?
Blood pressure spike.
What drugs are going to help you not get the blood pressure spike?
I think it'll be sort of agents that sort of will reduce the sort of the afterload for this patient.
So which opioid did you give?
I usually I know there's fentanyl, there's morphine.
And let's say you want the fastest acting opioid or one of the fastest acting ones. You may not have too much experience.
Okay. Yeah, so I understand that alfentanil works even faster than fentanyl. Is that correct?
Yeah, that's right.
Not too sure. Yeah.
Beautiful. So you give a big dose of alfentanil, you give a decent dose of propofol. This patient's otherwise well 50 50-year-old female, 80 kilos. So you might give the full, 150, 200 of propofol, because you don't need to worry about low blood pressure. You need to worry about high blood pressure.
Yeah.
And then just in case your laryngoscopy is a bit tricky and you're really digging in the vallecula and the larynx with that scope, I want you to have something else ready just in case you get this spike. So what's some other agents you can have that you can use that would decrease your blood pressure if you got a spike?
Ooh, so something like esmolol, potentially on the butyl, potentially you can also use. Yeah,
absolutely. So notice that this one, the patient was, the cardiovascular system of the patient was actually stable, except for this bleed potential. So really my goal is to avoid an increase in my transmural pressure gradient, causing a rebleed, which is the worst mortality event for this patient. And so I'd just give, fast-acting opioid. If you're doing a remifentanil anesthetic, often people would run remifentanil, and that's completely fine as well. You run 0.2 mics per kilo per minute, or aim at a target concentration. So affects a plasma target of maybe 4 nanograms per mil or something like that. You'd wait for your heart rate to drop and make sure the patient was asleep, obviously with the hypnotic, 2 milligrams per kilogram or 150 of propofol, and then you give a big dose of rock or sux. Now, even though I do this, like let's say I do this combination in lots of patients, every now and again I still get a blood pressure spike. So I make sure that I've got something else, whether it's IV lignocaine or phentolamine or esmolol. Esmolol and IV lignocaine are probably the most familiar things, and esmolol is just very effective and short acting and rapid acting. So that's probably, you're absolutely right. That's probably what I'd give. And I'd give a dose of anywhere from 0.5 milligrams per kilogram. So let's say in this patient, let's say 40 milligrams with another 40 ready if it's not working fast enough. Now, this is one of those things you probably haven't heard of, right? And so like with all of these cases, when I was going through my training, it was really just happenstance that, oh, I've got a subarachnoid bleed case. And then the consultant goes, actually, this is what's important. So even if you're just starting out, I want this to be a resource that you can look back on every time you get a tricky induction and you go, oh, okay, that's my priorities. That's my anesthetic. Oh, what's my consultant doing? Let's have a conversation about why you've done that, because now I've got a framework. So, this is the stuff I teach my final exam trainees, but really this is stuff that I think it's worthwhile having a framework and knowing very early on before even your primary exam, because then you'll have a better context for learning. Anyone had any changes or differences to that anesthetic?
Yeah, hello, heroes. It's Jackson. Mine's slightly different. So as you mentioned, Remy, that's something that I would do, plus a TIVA anesthetic with the propofol. The reason for Remy is because the extubation, I'm thinking about the extubation as well. Mm-hmm. They've had neurosurgery, and typically with most patients, when you extubate them, they do cough, and that increases the intracranial pressure. I'm worried that, if that causes a rebleed, then kind of what you've done in the entire surgery is kind of wasted. I've seen a Remy wake up, and it's really nice. You can open your eyes, open your mouth, done.
I totally agree, Jackson. Like actually for this case, when I do this case, I just like that alfentanil is so familiar to me that I use alfentanil. But then after I've given that, then I run Remy. So I completely agree with you. For a neurosurge case in general, I'll run Remy I need a rapid wake up for rapid assessment and minimal chance of coughing on extubation. So yeah, preaching to the converted, I would always use Remy for this case at some stage in this procedure. The reason I use alfentanil is just I can't bolus Remy as easily because you get some serious bradycardias happening. And often it's like a rapid sequence induction. So it's kind of, you're trying to play with a stable induction versus a rapid induction. That's why I give alfentanil.
All right, thanks.
No, great point.
Well, Lahiri, just so I understand it, why do we bolus alfentanil and why do we do an infusion for Remy? Like what I thought that they were both pretty fast acting, so I just don't quite understand the difference between the two.
Yeah, it's a good point. So theoretically, alfentanil it's a pKa. So pKa refers to the lower the pK of this weak base, the more unionized fraction of the drug there is. Unionized fraction of a drug has no charge, therefore it can, cross membranes a lot better. So now, the problem with Remi is, even though it's got what would seem to be a slightly higher pK than alfentanil, for some reason it seems to act in a far more effective and probably even a faster way than alfentanil does. And so, yeah, it's one of those things where theoretically alfentanil is faster, but really it's it doesn't. So theoretically alfentanil is faster, but remifentanil seems to have an onset that's even quicker and has far more significant bradycardias. Like, bradycardias are so severe, you can see them sometimes get down to 30, 20, whereas I've never seen that with alfentanil. The number of times I've had chest wall rigidity with remifentanil is far more often. It's almost never happened with alfentanil for me. So we don't bolus remifentanil, in summary, because it's faster onset and it's very effective. And for some reason, that causes all the problems of bradycardias and chest wall rigidity. That's generally why. If you do want to bolus it, like you'll see in the programmed pumps, when you start an infusion of whatever, 0.2 mics per kilo per minute of Remi, it will load the patients with 1 mic per kilo of Remi. So it will do a bolus, but that bolus is just very slow and controlled. Whereas when I do a bolus, and where anyone does a bolus, generally we don't have the manual dexterity or the patience to just go really slowly with a small syringe. And, I'd almost just encourage you to, I don't encourage you to bolus Remi in a fast way, but, in a young fit patient, so this is interesting, right? So there's a method of a rapid sequence induction, which you don't use muscle relaxant for. So this is something I've not done, but occasionally I hear people doing it when they really don't want to use a muscle relaxant. And you give a decent dose of remifentanil, let's say 1 mic per kilo, maybe up to 2 mics per kilo, but you also have ephedrine within that solution. So you're giving a decent dose, like maybe 10, 12 milligrams of ephedrine with your dose of Remi. And what that does is it avoids the bradycardia. It gets them super obtunded quickly. So you can put the tube in and you avoid a lot of those problems of bradycardia. If you were to Google that or search that particular technique, you'll see. But that's pretty much why. Sorry, that's a long-winded explanation of why I would do that.
That's perfect.
Okay, Tamponade. So let's say a 60-year-old male, 80 kilos, day 2 post-CAGs, with an acute pericardial collection causing severe tamponade physiology. So the blood pressure is 80, heart rate's 130. And again, I'll give you a context, because this is kind of the common context. If you get a patient that comes in from outside the hospital, often they've got like some kind of renal failure or some kind of infiltrative pathology, maybe malignancy, that causes an effusion that's slowly growing. And that's one of the ways you'll present with a tamponade. The far more tricky one you get is either a traumatic tamponade, which happens every now and again, or you have a patient who's had cardiac surgery and that for some reason that those vessels have failed or something has been cut or lacerated, and now you've got an acute collection. So the patient is in ICU, they've had their CAGs a day or two ago, now something's gone wrong and the heart is suddenly filled, and they've done an ultrasound and they go, oh wow, there's tamponade, we need to get them straight to theatre for a sternotomy and to fix whatever is going on. So you'll already have the outline in, you already have a central line in generally, and tamponade's occurred, you get them to theatre and they'll do a sternotomy and sometimes even go to bypass to try and fix this problem. So, but you're there, it's urgent, perfusionist hasn't come there, surgeon is there ready for whatever you need. What are your goals on induction for this particular situation? So yeah, take 90 seconds, and I might ask Johnny if you'd give an answer. Again, don't worry if you haven't seen this or done this. We'll go through, because I don't expect you guys to know this. This is often final exam stuff, but again, worthwhile knowing now. And Johnny, what do you reckon?
So I think in this person, it looks like, they might be in some obstructive shock. And I think my priorities would be to firstly maintain some degree of preload, given that they're probably actively bleeding, may need some fluid resuscitation. I'd probably aim for a normal rate, sinus rhythm, and make sure that contractility is not compromised, and aim for a adequate afterload in order to maintain perfusion to the heart.
Yeah, good. I'm going to stop you there. So just to clarify, the bleed has happened, but it's contained. So you're not necessarily giving preload and fluid for blood loss because it's a limited amount, but you're definitely giving it because now you've got, the heart was like this, and now it's, your maximum amount that you're of lusitropia, of diastole, of filling of the heart is limited now. So you need to push you need to get a high preload to push volume in there to maximize your cardiac output. The afterload, now think about, you've got this now increased pressure because fluid has surrounded the myocardium. So what do you reckon about your afterload? Do you want it normal, high, low?
Probably low.
So I'm going to say high because your coronary perfusion pressure is so imagine the coronary is going into your muscle. The back pressure is now so high that you need your coronary arterial root pressure to be really high to just get that blood in that and the oxygenation into the myocardium. So all of this is just this really interesting circumstance where you've got a sick patient that you need lots of volume, you need a nice high blood pressure, and you need to promote a fast heart rate because they're already going to be fast in their heart rate just to support their blood pressure because now they've got such a limited amount of diastole occurring. But essentially, you will keep their contractility high, heart rate high, volume high, and afterload high. And that's your tamponade situation. Knowing that, I just think of adrenaline as the cheat for this. I'll probably be running adrenaline for this patient just beforehand. And your aims are essentially whatever adrenaline does, which is preload high, rate high, contractility high, afterload high. So that's the way I imagine tamponade. The induction is a pretty specific induction. Has anyone seen or done a tamponade case?
Yeah, I have done it.
Yeah, go, Renika. What do you reckon?
Yeah, so actually there was a little bit of different situation. So patient was almost like a collapsing because of the tamponade. And my consultant said that we will do it, keep the patient on the spontaneous sort of ventilation to avoid the decrease in preload. Because positive pressure ventilation cause increase in the preload and that will further cause the catastrophe. So what he did is he gave a generous amount of ketamine and give start a little bit of SIVO. Surgeon was there and then because it was the same post CABG patient. So with the local anesthesia, they opened the chest and drained the tamponade. That's how we did it at that time.
Fantastic. Hey, so you've raised a lot of good points. So when I think of the spiel for tamponade, you've got to mention all of these things. So often you can do partial drainage just with ultrasound guidance, and the cardiothoracic surgeons are all over that. So, if the tamponade is severe, it's so high risk that you want to put a needle in, ultrasound guided, and relieve the tamponade prior to doing induction. So you might be able to do that with local anesthetic and a bit of sedation just in theater. Next thing, you've got to do the induction, right? The surgeons are scrubbed and ready. So if your induction causes a crash, the solution really is sternotomy, evacuate the clot, and then resuscitate that heart, because the surgeons can be right there to solve the problem very quickly. So partial drainage, surgeons scrubbed and ready, and exactly what you said, Renika, the typical theoretical induction that they talk about, which you'll be required to talk about, is to avoid PPV, positive pressure ventilation, to maintain cardiac output with those priorities that we talked about. And this typical technique that Australian anaesthetists have talked about is the inhalational induction. So when I've done this, it's literally been this really tricky inhalational induction. Everyone's ready to go if the patient crashes. We get the patient deep enough, increase the adrenaline, support the blood pressure, do whatever it takes, and then you put the tube down once they're deep enough, and then when they can do the sternotomy. You can slowly increase your positive pressure ventilation, and only then, if they're tolerating it, do you give paralysis and then continue with the surgery. Anything goes wrong, surgeons are ready, sternotomy and open. So these are the points that you would say in this induction that are different to all these other inductions. I just want to make the proviso that there's plenty of people who are just doing a rapid sequence induction and giving positive pressure ventilation, and these patients are doing fine. But this is kind of the theory that most Australian anaesthetists would expect you to say, even though doing a rapid sequence is done in plenty of centers around the world. Any questions about that induction? Hey, so we've gone for about 1 hour 15 so far. So just the quick summary of that. We've gone through critical cardiac, hypovolemic shock, pulmonary hypertension, subarachnoid bleed, and tamponade. And these are all the points of difference we've gone through for each of these. The priorities are different.
Oh, yeah. Do you worry about blowing your grafts with adrenaline, or in this situation, we know we're hypotensive, so we're not going to overshoot? Like, once the tamponade's corrected, do you have to get them off adrenaline pretty quickly, or?
Yeah, once the tamponade's corrected, you can see a massive jump in your blood pressure. So you'd be ready for that. You'd be communicating with the surgeons, hey, how's it going? And it's not always an immediate thing as well. So you're just being vigilant to the change in hemodynamics that's occurring at any time, really. So that's pretty much it. I don't worry about blowing the grasp, as in I'm not trying to aim for a 200 millimeter mercury blood pressure. I'm really just keeping it at a higher range, even if it's 120, 140, I'm just keeping it high enough that I know I'm going to get some kind of perfusion. So the high end of normal. Yeah. Hey, so the next thing, so we've gone through kind of the cardiovascular relevant stuff, which is essentially heart and systemically. I thought the valves were a very specific group that are easy to memorize if you look at them in context and together and compare them to each other. So yeah, just want to give you an introduction to the important valve lesions, identify severity and stability, I'm about to say, and how to approach a safe anesthetic for each of them. So what's common and what's deadly? And so the common stuff really is aortic stenosis. We've all seen a lot of that, mitral regurg. And when I was working in Darwin, even in Broome, there's just a lot of mitral stenosis in the Indigenous population due to rheumatic heart disease. And so then that's common, but what's deadly is really aortic stenosis, mitral stenosis, and HOCM. And these are the things that are really not well tolerated under anesthesia. So even though we go through this table and look at the aims under anesthesia, I really care more about these lesions and the stenotic stuff than the regurg stuff. So let's talk about severity. Does anyone, actually, I'll just go through this because it's just this is one of the older tables from the ACC-AHA guidelines. So the American Heart Association, the AHA, and the American College of Cardiology, the ACC, these are the kind of the bodies that put out all of these really great guidelines and summaries of all the heart lesions, whether it's rhythm disturbances, valves, heart failure, or acute coronary syndrome. And this was from some of the older stuff showing that the definition of severity of each of these is pretty much valve area and pressure gradients. It's changed slightly, but this is a lot of the stuff that people still use. And so I thought I'd use this. So it's changed slightly with some velocity of jets and things like that. And like anything, tables are annoying to memorize, but when I try to memorize these tables, I just really look for the middle value. So, you'll be really impressed if you know that, moderate aortic stenosis is 1 to 1.5, you just remember that range. And then below that is severe and above that below that is severe and above that is mild. I know that sounds pretty obvious, but people trying to remember 3 numbers when really you just have to remember 1 set of numbers there. Likewise, pressure gradient 25 to 40 is the pressure at which you've got a moderate lesion, less is mild, and greater than 40 is severe. Yeah, good. Now, what's important? So obviously a small valve area in a stenotic lesion is bad. Smaller it is, the worse it is. Now, if you have a small valve area plus you have symptoms, that's very bad. And then, as you saw, sometimes, very occasionally, you'll get a patient with a valve area that seems bad, but then a lower pressure. So you might be fooled into thinking, like, let's say aortic stenosis had a severe valve area of less than 1, but then they had a 40 in the range of 25 to 40. That's not a great thing. It just means that potentially your ventricle is failing, and not that this lesion's actually moderate severity. So, any kind of low ventricular ejection fraction and low pressures may mean that your heart just isn't pumping effectively and it's already started to fail. So the anesthetic plan for this is often, GA or regional can be done. Often we talk about aortic stenosis being a contraindication to doing a spinal anesthetic, and that's what a lot of people talk about. I don't necessarily completely agree with that, because I think as long as you're targeting certain maps and supporting the blood pressure, a GA could be just as hazardous. But just to know that in the Australian kind of culture of anesthesia, people try to stay away from regional anesthesia for severe aortic stenosis lesions. You almost always want an ECT with paralysis. You often will have all your monitors, maybe a 5-lead if their heart is bad, rather than just a 3-lead ECG, and an art line. And maybe, really, really rarely you'll have a CVC and a toe for the induction. Really, like most of the situations you saw before, an art line is really the only addition that you need to keep things safe. And then you just need your inotropes and drugs ready to target the priorities that we'll go through. And maybe an extra anaesthetist, and occasionally I've had to put defib paddles on just in case the patient has an arrest and you just want to have very little time to shock them back into rhythm. So that's your anesthetic plan. Now, the first drill we're going to do is, what are the main cardiovascular priorities with the main valve lesions, plus tamponade, plus Hockham? I thought just putting them all together is really, really useful. So you've got a table in your workbooks. I want you guys to take 3 minutes or so and just fill them out. So, often, like, the way I want you to write this is for sinus rhythm, for example. Sinus rhythm is either critical or it's acceptable that it's not critical. So just write sinus rhythm critical or not. And then, the rest of them just say full or, low, high, whatever descriptive term. So take 3 minutes, go for that. And I'll just get a volunteer to kind of run through that in, say, 3 minutes. Hey, I think maybe some people didn't get the workbook, so I'll attach it now and send an email to everyone if they don't have it. Actually, I'll just send it to Jackson. You don't have the workbook. Does anyone else not have the workbook?
I don't have the workbook at the moment.
Oh, who's that? Who just spoke? Sorry.
Max. Sorry.
Max. Good. Max and Jackson.
Hello, here. I also don't have the workbook.
Yeah. Can you Zheng and Jackson, could you type your emails into the chat and I'll send it to you now. Ramesh, can you please also put your email in the chat? Okay, that's sent to everyone. Good. Hey, who wants to volunteer? It's been 5 minutes. Who wants to volunteer just to go through this table?
I'm happy to volunteer here.
Panic.
All right, so I guess we'll start with the first one that's already got the answers written in there. So aortic stenosis, we generally want good preload to make sure that we've hit the optimum point of the Frank-Starling curve. Low to normal rate to allow for good end diastolic filling. We want to make sure we attain sinus rhythm, because any sort of deviation from that, if you go into AF or SVT or anything like that, you would drop your cardiac output significantly, given that you've already got that stenotic valve. Contractility going to maintain normal. In terms of afterload, you've got this really thick myocardium, and it requires a high amount of oxygen, so you need to make sure you've got that afterload there to maintain coronary perfusion. Aortic regurg and mitral regurg.
I'll just emphasize that as well. So how about the low normal rate? Why do you want that?
So the low normal rate, I think about it as end diastolic filling. Mm-hmm. So it allows for some time for preload.
Yep.
And the reason so that you've got adequate pressure, so the pressure inside the ventricle exceeds the pressure on the other side of the aorta.
Is there any other reasons why you'd want a low normal rate, knowing that you're a thick myocardium?
Oh, to reduce the oxygen demand of the myocardium.
Fantastic. So you've got this heart, it's got a really bad obstruction it's working against, and the muscle is thick, like you mentioned, from having to work against this really high afterload for a long period of time. So it's that now you've got to really reduce cardiac output. The stroke volume is just low, maintain full preload, low heart rate to preserve oxygen, decrease oxygen consumption. Without sinus rhythm, you lose your ejection fraction. Contractility must be high to push against that real big obstruction, and like exactly like you said, high afterload to perfuse that thick myocardium. Good. So one of the mnemonics that gets kind of bandied around is slow sinus squeeze, slow heart rate, sinus rhythm is critical, squeeze meaning you want vasopressors to squeeze your venous system and your arterial system. So slow sinus squeeze is like the mnemonic for that. Go for it, aortic regurg.
Yeah, so aortic regurg and mitral regurg I think about very similarly. And the issue here is you're struggling to get blood to go forward because it's regurgitating back because of an incompetent valve. So in terms of preload, I like to you want to keep the preload full. You want to keep it in the high to normal range to make sure that you're actually adequately filling the ventricle to allow for a good ejection fraction / cardiac output. In terms of rate, you're going to be going fast because you want to limit the amount of time there is for blood to regurgitate back as well. And cardiac output is stroke volume times heart rate. So keeping your heart rate high if your stroke volume is a little bit lower will compensate for that. Rhythm, so sinus rhythm is what you're always going to want, but I mean, it's not as important as aortic stenosis or Hocken. In terms of contractility, we're going to try and maintain that normal. And in terms of afterload, we don't want much afterload because we want to make sure that we can eject blood forward. So afterload is the force at which the heart has to contract against. So if there's a lot of force, it's only going to go backwards if you've got an incompetent valve.
Beautiful. Do you know the mnemonic that they...
No.
Yeah, full, fast, forward.
I saw that in the chat. Yep.
Yeah.
Actually, what I think about when I do it, but I didn't think it was the mnemonic.
Yeah. So yeah, full preload, exactly what you said. Again, all of these lesions, you're just trying to get on balance, you're trying to get a good forward flow of cardiac output. But the problem is sometimes having a fast heart rate for forward flow or a low afterload causes problems like an aortic stenosis where you get the ischemia problem. Aortic regurg doesn't have that problem of having a really thick ventricle. It's a dilated ventricle, but it's not thick. So you can keep full preload. A fast rate promotes forward flow, and a low afterload promotes forward flow. Often these patients are in atrial fibrillation anyway, and it's not as critical. It's probably well tolerated, and contractility you'll maintain as well, but you don't have a big resistance or afterload to eject against. So the other thing is they talk about regurgitant lesions being well tolerated under anesthesia. So just to give you a bit of context, and just take this as kind of an advanced thing. Anytime you get a patient with a valve lesion, you want to take it seriously. You tell your consultant, you appropriately optimize and investigate and make a plan for it. But just know that when I see a regurgitant lesion, I don't worry too much. Regurgitant lesions are well tolerated under anesthesia, especially because anesthesia tends towards hypotension. So therefore, giving an anesthetic probably helps forward flow. And it's very easy for me to get the heart rate up with a bit of atropine or glycopyrrolate or ephedrine as well, if you wanted. So regurgitant lesions, full fast forward, well tolerated under anesthesia. I might ask someone else for a bit of variety. Anyone want to tell me about mitral stenosis?
I could probably give it a go.
Go for it.
So I think it's like mitral stenosis. One thing you're worried about, typically you have like a dilated left atrium that's constantly pushing against pressure. So initially, like you want to maintain like a good preload to encourage adequate left ventricular filling. So rate probably like on the slower side, just to give more time for diastolic filling. And obviously, because they've got a dilated left atrium, the high risk of AF. So maintaining sinus rhythm is very important. Contractility typically sort of normal. And you can use inotropes if needed, and afterload typically sort of adequate as well.
Yeah, that's all good. Now, there's just one of these situations in often we get these pregnant patients who have sudden autotransfusion post-delivery, and they come in, youngest patient with mitral stenosis. So we try to aim at a normal preload because the sudden increase in preload can drop these patients into APO, and that's just one of the very specific contexts of it. But yeah, that's right. Normal preload. Watch out for a full autotransfusion in certain situations. Low normal rate, sinus rhythm. You'd really want sinus rhythm, but often they're in AF anyway, contractility maintain, and afterload I maintain at a higher level. While you're there, what do you think of HOCM?
Yeah, so for HOCM, I think you'd want to maintain sort of a normal preload. Also, it's too high, like you probably have like a failing left ventricle as well, so you don't want to keep it like too high. That would precipitate like further like worsening of your left ventricular systolic function.
Actually, let's talk about that. The preload. What is the problem? What's the pathology with hypertrophic obstructive cardiomyopathy? Essentially just hypertrophy of the muscle, so you get sort of less area there. So it's like can cause like a systolic dysfunction, and also like partially like impaired diastolic filling as well, because like the area is reduced. Yes, I'm just going to do a really bad diagram of a heart. So hopefully you can see that. Imagine that that's your normal heart, and suddenly you've got a really, hopefully you can, I've got the focus set wrong, but now you've got an obstruction to the outflow tract. If you have, what's preload going to do to that obstruction? So if you have a low preload, so not much volume, what's going to happen to the obstruction, do you reckon? It could get worse. Exactly, yeah. So for that reason, you do want to create high preload to open up that channel. Oh, I see what you mean. Yeah, sort of dilates the left ventricle. Exactly. Keep going. So rate, you mentioned low. So rates, obviously you want a good inotropic force, because like with this, you might have like left ventricular failure. So you could use inotropes if needed. So you want to maintain, so with what you're saying earlier, maybe you want to actually just maintain a heart rate that's slightly lower, just to encourage diastolic filling. Yep, cool. And because it's a thick wall, you might have that problem of ischemia as well, just like with aortic stenosis. So exactly. Yeah, so you want to avoid like tachycardia as well, so precipitate like an ischemic lesion. Tell me about afterload. What's your afterload? So afterload, I think you'd want sort of probably like a normal range. And why? You got a thick muscle, and why do you want a normal range? So if your afterload is like too severe, that it'll like increase the force that the left ventricle has to work against. So ideally, you want it in a normal range, and then similarly, if it's too low, because you're not creating adequate force as well, you risk like hypertension. So I think normal would be ideal. Look, and you're right to balance the problem of I'm using a lot of energy to pump against an afterload, but then you've got the problem of perfusing a thick ventricle. So So I'll just kind of go through this. Interestingly, you can see these patterns now, right? So HOCM, full to open up that channel to stop the hypertrophied wall touching itself, therefore causing obstruction. Low normal heart rate because you want to decrease myocardial oxygen and promote that filling. Sinus rhythm is critical. You just need to get as much filling of that left ventricle as possible. Afterload high, or let's say normal high, to promote perfusion of the thickened ventricle, just like in our AS stenosis. But the one difference between AS and HOCM is this odd thing. The contractility you want lower. That sounds like a little bit odd, doesn't it? The problem is this is a dynamic outflow obstruction. So they say dynamic outflow obstruction because it's not stable like an aortic stenotic lesion. It doesn't just sit there at a certain aperture. If the muscle contracts vigorously, it closes off more. So essentially, if you've got a HOCM patient who gets hypertensive after doing all the other good things of giving fluid and giving aramine, if you still have really bad untreatable blood pressure, the thought is that you give a bit of esmolol. So you just give a bit of esmolol to drop back the contractility and open up that channel. I don't know what the evidence of the efficacy of doing that is. It's just one of the things that are talked about in our context with HOCM. I'd still do everything else that I do. And then if none of this is working, instead of getting my ephedrine out, I'd give esmolol first to see if that promoted blood pressure. Okay. And esmolol, is that like more selective for like the cardiac receptors or exactly more resistance? You'll see in anesthetics that often, if you have any reason to use a beta blocker, use esmolol for two reasons. You give it and it's cardiac selective, so it's beta 1 selective instead of also beta 2 blocking, which can cause peripheral vasoconstriction and bronchospasm or bronchial constriction. So beta 1 selective, first reason. And second reason, it's very fast onset and fast offset. So it's very forgiving. If your reason for giving it is wrong, you haven't burned your bridges. If I gave a big dose of metoprolol, it's going to be a slower onset. So I'm not even sure it's going to be working necessarily until 5 minutes time or so. And then it will last for 15 to 30 minutes at a standard kind of 1 to 2 milligram dose. So yeah, esmolol, very forgiving, on and off, and I can see whether what I was doing worked. It's one of those, it's one of those drugs that is very unique to the anesthetic context. We have a lot of drugs that aren't metabolized by liver or kidney. Liver and kidney metabolism is generally slow, but we have a lot of drugs that are metabolized by esterases. Esterases are just these enzymes that exist in the plasma, red blood cells, and other parts of the body, and there's just an abundance of them. So you just get elimination of remifentanil with esterases, esmolol, atracurium, and cisatracurium as well. That's a bit slower though. But yeah, you just get this really rapid offset because of these super abundant esterases. And finally, we've already gone through tamponade. It's the adrenaline thing, full, fast, sinus, high is what you're kind of targeting. So again, just notice the patterns there. AR and MR, pretty much the same. AS, MS, and HOCM, pretty much the same, except for MS, you might just want a normal-ish preload because you're worried about precipitating pulmonary edema, and HOCM, low contractility. And this is just one of those things, I learned this very piecemeal throughout until I got to my final exam. I just don't see any reason why you can't just have this as a resource and just know it. So you've got another table in your books. How would you perform your induction for a patient with severe disease? So imagine severe disease of each one of these lesions, and imagine a 70-year-old, 70-kilo male with severe stenosis, severe aortic regurg, severe mitral stenosis. Using a table and priorities, what do you do? Think about extra monitoring above your standard monitoring. So let's face it, it's always going to be an outline. Think about your induction doses, and then which inotropes and vasopressors are best for your situation. So it might actually take 5 minutes. That's probably a bit of stuff to do. And then we'll go ahead with someone volunteering. And yeah, so I'm just kind of giving you the aortic stenosis arterial line, 3 midaz, 100, 200 fentanyl to stop the fast heart rate, 30 of propofol to avoid too much problems with contractility. And then metaraminol is my inotrope of choice. So yeah, just fill that out. We've already gone through tamponade, so don't worry too much about that. But MS, AR, MR, HOCM, take 5 minutes and I'll get a volunteer. Okay, so that's about 5 minutes. Hey, does anyone want to have a go at the induction for mitral stenosis?
Yeah, I'll have a go, Lahiro, for mitral stenosis. So I think for monitoring, it would be very similar overall to the aortic stenosis. The part that stood out to me, though, was that because we're aiming for lower preload because of the risk of APO, that would be the main change to it.
Yeah.
In terms of monitoring, I get an arterial line, and I don't know if lung ultrasound is very practical here, but if you're considering APO potentially something to do, I don't know if that's more theoretical than anything else.
Yeah, it's a good thought, and maybe it will happen in the future, but no one would do that at the moment. But yeah, good thought.
So we'll just get an outline then. I think the induction agents would be very similar as well. I think we're trying to let me just have a look at my notes again, but we're trying for a low normal rate, so we need a decent amount of opioid. He weighs 70 kilos, so I'd give 350 of fentanyl. I think that in terms of induction agent, I'd probably give a good amount of Midaz. I might give 5 of Midaz and 25 of propofol for the induction agents. In terms of inotropes to maintain the afterload, I would consider metaraminol rather than going for something like ephedrine, which might have a chronotropic effect and go against our low rate that we want in this case.
Yeah, sounds good. Yeah, I completely agree. And again, there's going to be a lot of variation with this. I'll see plenty of consultants might just give propofol, but I feel like I know I've got this problem and I don't want to give too much propofol. I don't want to give too much SIBO to avoid real problems with contractility and afterload preload. So I'm a big fan of using Midaz for those reasons. How about AR and MR? Is they're probably a bit similar. What do you reckon for that?
So I think the same thing. Arterial line, and as you mentioned earlier, these are probably better tolerated under anaesthetic, with the reason being because our afterload, we want a lower sort of afterload, and that's going to happen regardless if we give a good dose of propofol and all that. So what I had down for this was probably going something like propofol 100 milligrams and fentanyl 200 milligrams there. We could give a bigger dose of propofol here, and we're not quite as worried about the vasodilatory effects there. And if we're going for inotropes, we'd probably consider more ephedrine or adrenaline, and maybe have adrenaline ready as well in this case. We don't really mind having a faster heart rate.
Sounds good. And with that arterial line, like let's say some things are never hard or fast. Like often I'll just do these, if it's severe MR and AR, I might do it without an art line just because I'm so confident of them being well tolerated. But let's say the case is a slightly bigger case. I'll, at a junior level, have a low threshold for saying art line, because first you get to put an art line in and you want to put lots of those in. And second of all, you want to be cautious. And third, over calling certain things like that is I think far better. So yeah, that's good. AR and MR are very similar, and we'll go through that in a second. Yeah, while you're there, Calvin, Hockham, what do you reckon?
So Hockham, I didn't actually get to write this one down in the end, but going off it now, I think Hockham, I'd be concerned about that obstruction, and I think that I'd probably want to have an art line and defib pads and an extra anaesthetist, all those extra things that you mentioned, and also potentially a transesophageal echo as well to have a look for any obstruction as we're doing the induction. In terms of induction agents, the priorities again are going to be, we want full preload, we want less contract, we don't want too much contractility, we want a good afterload to make sure we have coronary perfusion. So I guess with less contractility, that's good. We can put propofol, we can give a 2 milligrams per kilogram dose. We could give maybe 150 of propofol in this case for this man, and we could give, and in terms of rate, I'll just have to double check the table for that, but we want a low normal rate as well, so we can definitely give a good dose of fentanyl for it. We could give 200 mics of fentanyl with that too. In terms of inotropes, I'd be very reluctant to give ephedrine or adrenaline in this case, because we'd be trying to avoid increasing that contractility to avoid outflow obstruction. We'd have the esmolol on hand, and if we really needed it, we could potentially use some metaraminol to help with the afterload and potentially the preload for that.
Yeah, beautiful. And so the one thing is, because it's a 70-year-old, 70-kilo male, who's got some severe disease, I'd always err on the lower side of propofol. So I wouldn't give the 2 milligrams. I'd probably go to the 0.5 to 1 milligram per kilogram of propofol rather than the full 2. That's the only thing I'd change with that.
Yeah.
But yeah, so this would be the setup. Feel free to take a screenshot of that just in the interest of time. And you can see that, yeah, like literally AS and MS I'd approach very similarly, except the fluid, as you mentioned. AR and MR, well tolerated. I'd still give a big dose of whatever. Fentanyl, 50 of propofol would be fine in this patient, even 70. Ephedrine is my inotrope of choice because I want forward flow. Hockham, again, arterial, I really want for that because of the very rapid decrease in outflow that occurs with this lesion. But and then the induction looks so similar to the aortic stenosis induction. I do want metaraminal, and I might have esmolol just ready. So again, you can see these patterns. You can memorize a lot easier when you see these patterns. And then we've already gone through the Tamponade induction with all the kind of specific things that you'd have to mention on top of your induction, like having the partial drainage and the surgeons prepped and draped. Any questions about that?
Can I just ask a question regarding mitral stenosis and the consideration of metaraminol for the inotrope? Mm-hmm. Would the concern of kind of increasing venous return and possibly increasing the risk of an APO come into your consideration when choosing kind of metaraminol as your pressor here?
Yeah, it's always the concern. Look, it's just not a. Yeah, I completely see your point.
It might be too academic, and if it is, you can just tell me.
Yeah, I've got so. It's a really good point that you say that. A lot of this is quite academic. Like there's good principles to follow. And when you're presenting this stuff to your consultants, this is probably a good thing to follow. But you're absolutely right. Like too much metaraminol will cause too much venous return and may precipitate something. So yeah, I tend to agree with you there. Like you just be cautious whatever you're doing. Like, all of this stuff with any kind of bad heart lesion or bad cardiovascular state really just requires a slow titration. So when you see the problem, you've got time to treat it. So that it's a really good point that whatever you're doing slowly, and just know that all I'm telling you is 5 parameters and maybe something extra. The heart is far more complicated than 5 parameters. This is just the way we model it to make it understandable to us. So yeah, I take everything I say knowing that probably the biggest thing about all this is some priorities, and you take your time to induce, and if you can, and then you predict the problems and get ready to treat them. Thanks for raising that point, though. That's good to go through. Any questions about the valve lesions, or anyone have any different kind of inductions, or want to raise a different induction that they've seen, or think? Yeah, go for it.
So I was just going to say with Hockham, I read something about a fentanyl/volatile agent induction.
Yep, absolutely.
Having the propofol and the DAS on board as well, just because the volatile would cause a bit more, I guess, more selective myocardial depression.
Yeah, absolutely. So Sevo will be more myocardial depressant than propofol. So yeah, if I had to choose one or the other, my induction would still be to get them asleep with propofol, but then I'd start bag masking them with volatile to get that up. So, and again, it probably doesn't matter too much, but yeah, that's absolutely theoretically, I'd want sevoflurane for that reason. Yeah.
Nice.
Hey, so just a quick summary. That's all your cardiovascular stuff. Critical cardia, hypovolemic shock, pulmonary hypertension, subarachnoid bleed, tamponade, valves, and Hockham. And let's now go to, there's really just 3 kind of critical airway inductions that are at a serious level. Obviously, I've done my airway talk, which I'll hopefully put up soon, which is all the other airway assessment management stuff. But then these 3 things are really where, again, at an advanced level, it's better that you know a framework now than later. So first scenario, a 7-year-old male for a lap collie, severe ankylosing spondylitis. So just imagine this patient looks like this, they've got a fixed flexion of their neck and no extension at all, really. Mouth opening is 3 centimeters, Mallampati 4, limited jaw protrusion, thyromental distance. You can't really calculate because you can't get them in the right position. What's your gut feeling of that, Rose? What do you think you have to do for the airway?
So it's just concerning in terms of how I'm going to be able to access it. So I'd be thinking about, I've never seen it, but an awake fiber optic intubation potentially.
Beautiful. All of these, I've made this kind of really obvious that every single airway assessment on examination is just terrible. So Mallampati 4 is bad. Mouth opening 3 centimeters is like the minimum you need really to put an LMA in. Limited jaw protrusion is bad. Thyromental distance, fixed neck really makes everything terrible. So an awake technique is exactly what you need. An awake fiber optic would be kind of the gold standard for how to manage this. Who's done an awake fiber optic or seen one? Cool. Hey, Renika, you would have done one of these, yeah?
Yeah, I've seen, I've done as well.
Yeah, do you have a framework for how you prepare this?
Yeah, so starting from the pre-induction, like maintaining the airway. So I would like to give some anxiolytic.
Yeah, beautiful. So we'll go through sedation.
So the sedation part, to decrease the secretion, I would like to give some glycopyrrolate as well.
Beautiful. So secretion stuff, yep.
Yep. Then to prepare the airway, so I would start preparing airway with the local anesthetic. So starting with saline goggles, some lignocaine jelly through nose, and some blocks, airway blocks to anesthetize the local airway. And then I generally start with some small sedation or sometimes the dexmedetomidine just to keep the patient calm during the procedure. And then I would like to go with the awake intubation.
Yeah, good. Hey, so the first thing is awake fiber optics are obviously can be incredibly hazardous. There's so many moving parts, and a lot of the equipment is kind of MacGyvered together. Like, you're sticking a tube on a bronch, and the tube doesn't actually fit on the bronch, and you got an anxious patient, and you're not really doing this technique too often. Plus, you're giving a patient with a problematic airway some level of sedation and some level of potent opioid like remifentanil, and they can stop breathing as well. So there's just lots of ways this goes wrong. So this is something that, again, I want you to have a framework so you can talk about it intelligently. So at least you can, it's hard enough to do, but at least as a junior, you can talk about it and checklist a lot of things. And then, when you first see one, you can probably even help out a lot by just having this stuff checklisted really well. So preparation, bronchoscope, sedation, cough, and secretions, that's all my drug stuff. Then the local anesthesia topicalization, then the procedure, and then confirmation. So these 6 things are the categories that I would suggest that you kind of chronologically are able to do. Now, I'm just going to go through this and potentially ask some questions. So preparation for me is always consent and IV access. That's kind of obvious stuff. We've already done that. So monitoring, assistance, drugs, and equipment. And really, all the next things so monitoring is probably a standard, maybe an outline, depending on how sick they are. Assistance is always having a very competent anesthetic assistant who's senior, who knows how to predict what's going wrong and help you out. You might even have another person, anesthetic, registrar or consultant with you. We'll go through besides the induction drugs and resuscitating drugs that you already have, we'll go through the stuff that you might use for sedation, antitussives, and anti-sialagogues for secretions. And then equipment is really your bronch stuff and how you manage that. So, you may have never seen this, or you may have seen this occasionally. You just need to have a framework. And even for my own practice, I don't do this often enough. Like I do a awake fiber optic once every 6 months, which is not very much. And the patient's often really in a dire situation. So I write this as a recipe and method. So I've got all my ingredients, and then I've got my procedure, and I just look at it, checklist it. I send a copy to my nurse, and that's how I make sure that nothing goes wrong, or to the best of my ability. So the bronchoscope, just know that when you check a bronch, you should check it yourself, and there's just a few things you need to do. I just turn on the image. I check that the light is on, literally what I'm doing there. I'm just checking that the light's on. There's a little moving device that retro and anti-flexes the tip. So I just make sure that that is working. And it's got 2 channels. One channel is the suction port, and another channel is what we call a working channel, where you can inject stuff into. Now, the one tip that I really hope you take away is that port at the end of your fiber optic is tiny. And so even though it's a suction port, if you were to actually use it for suction, you would just bring gunk and mucus and phlegm or whatever onto the image of your fiber optic scope. And so I use oxygen on that. You just literally just attach it to your oxygen outflow tract on your machine or on an oxygen cylinder. And then I check that that's working, because that way I'm going to blow muck away instead of bring and suction it towards me. That one tip I feel like is really, it's just been one of the greatest things that someone taught me back in the day. So I check that that's on, and then I attach a tube to this. Now the tube, a normal ETT is it just isn't the right profile. For example, if you look at a normal endotracheal tube, you'll see that this is a Parker tip tube. So this is kind of the one you want to have. So it has this little lip here. Can you see my arrow? That lip, that kind of, I guess, beak type look to it, means that it goes flush with your fiber optic scope. A normal tube doesn't have that beak, which means that there'll be a gap between your scope and your tube. That gap is what ends up kind of, if you imagine the vocal cords like that, if something's flush, it goes straight through, but if it's got a bit of a gap, it ends up kind of hitting like this, and it just impedes and really offends the patient when they're trying to do that. So the two tubes that are more flush and easier to pass are a Parker tip, which is this beaked tube, or a bullet tip tube, which is the tube you get in the fast track LMAs. It's like this reinforced tube with a very soft nib. Now you might ask, what did they use back in the day before you had fancy different options? If all you had was a size 7 or a size 6 endotracheal tube, you could put it in hot water or warm water, and that softens the tube to make it more malleable to pass easy. So that's the biggest, again, the greatest tip I got was, if you don't have fancy tubes like we have now, like maybe they've run out, there's always equipment shortages or back orders of things, I just make sure I put that in hot water. So yeah, just store this information away, because this is the stuff I wish I knew at the very start when I was going through my training. So yeah, that's it. That's my bronchoscope checked and loaded and the appropriate stuff attached. The other thing I can do is I can put an epidural catheter down the working channel. Just ask someone to show you it, but you don't really need to. I just get some saline and I just push it through the working channel at the top. And what I do there is I have a 5 ml syringe. I don't put 5 mils of saline. I just put 2 mils of saline to check it, or 2 mils of lignocaine in the future, because then I've got an amount of air that pressurizes, that squirts the lignocaine when I need it out the other end. So I check that before I start as well. Hey, any questions about the bronchoscope before I move on to the next phase? Now, sedation and antitussive stuff and antisyllagogue, this is obviously really important. Now, your options really are midazolam, opioids, and glycopyrrolate for all of this. So if I'm giving glyco, I give that very early on, because I need time to work to just dry up the secretions. So it dries up the secretions. I give 0.2 to 0.4 milligrams pretty early. Like as soon as the patient comes into the anesthetic room, I give that. And it has the added benefit of tending the patients towards tachycardia. The reason that's good is if I give remifentanil, that tends the patient towards bradycardia, and glyco just stops the bradycardia being severe. So glyco as soon as they arrive in. I then get the patient in to the theater, because everything else I do, this patient's airway is going to be really, really difficult. I want to have all my machine and everything ready. So I only give midazolam and the opioids once they're ready, seated or lying down. So midazolam, really, I'm giving tiny amounts depending on the patient, like 0.5 to 1 milligram at a time. And, it wouldn't be the craziest thing to have flumazenil ready, as long as they don't have any contraindications, like they're not on tricyclics, have flumazenil just in case you oversedate. So I just want the patient to be able to tolerate it, but I'm erring on the side of less than more. I want this patient completely, awake, responding, and definitely ventilating appropriately. Now, the opioid, there's many ways you can do this. You can run a remifentanil infusion, alfentanil, or fentanyl, and these are all completely doable. Most people I'd see these days run remifentanil, and it's a very tiny dose. Like normal surgical levels are 0.1 to 0.2 mics per kilo per minute. For this, you run 0.05 mics per kilo per minute. You just don't want to ever risk this patient becoming apneic. So it wouldn't be the craziest thing to have naloxone ready just in case. If they become apneic, you stop the infusion, you give naloxone, and that's how it is. And again, there's a lot of ways this goes wrong. Running Remi, like a bit of the subtleties to this, you usually have Remi in 2 milligram vials or 1 milligram vials. I always dilute it into a 50 ml syringe, maybe even double dilute it to make sure it's roughly 20 mics per mil. If I have a higher dilution, like 50 mics per mil, imagine even a little bit of error, a bit of a flush that's gone wrong, or, whatever, you suddenly have an option, the chance of this patient becoming apneic. So I dilute Remi into it, like 10 to 20 mics for this procedure. Alfentanil, again, I want something that's very efficacious and pretty rapid acting. So I don't give the full 1,000 like I normally do with most patients. I give 200, 250 at a time, see how they're responding, knowing that the peak effect is roughly in a minute. So I might wait 2 minutes just for a margin of safety. Now that's the kind of drug side of things. Any questions about that?
I guess very quickly what I wanted to say, I was reading in Life in the Fast Lane that often they use ketamine's another thing you can use, but I guess the secretions and stuff that would result from that would be, thinking about it now, I probably wouldn't use it.
And I want the patient completely with it. They need to obey instructions. So I'd probably never use ketamine, but in the ED context, like Life in the Fast Lane, like it's one of my favorite websites. They would often do these like delayed sequence inductions, and they use ketamine for that. But do they say using ketamine for fiber optics or?
Yeah, that's what I'm pretty sure I read. Either opioids or like a remifentanil infusion or small amounts of ketamine.
Okay, so they could be talking about, let's say you've got a really tricky patient who's got a difficult airway and is combative, then ketamine is probably the better drug to keep your ventilation going, plus keep this patient non-combative. So that would be like super difficult, super advanced. I'd have my surgical airway stuff ready because it's so easy to have this patient obtunded. But yeah, ketamine, fantastic drug, especially in the ED context when like these patients are coming in electively in the anesthetic context. It's a lot more controlled. If I was an ED, I would do all of this stuff plus ketamine if they're combative.
Got it.
Hey, so the local anesthesia, now this is the one that has the most variation. And so when you're thinking about this, like I'll tell you this now, and every single consultant you work with till you graduate will have a different technique. So the aim of this is to definitely see all those techniques and say, I think that one worked the best. And you'll realize that none of them work the best. They're all just a different way of doing it. But you know what? Have a way that you can, your job as a resident and junior registrar is to give your consultants the confidence in you to give you enough rope to go ahead and do these procedures yourself. So by knowing this system, when they say, when you're about to get an fiber optic and you go, oh, look, I'd really like to help you on this. Do you mind if I run this plan by you? If you can impress them with your plan, they're far more likely to let you do some or part of this. For example, if you came to me, never seen one, never thought of one, then I'm doing the whole induction. You're watching me and that's it. If you came to me with a plan, I would probably let you do the fiber optic at least. The fiber optic is challenging enough. The sedation and topicalization is probably the hardest part of it in managing this situation. So I'm hoping that you can at least give them the confidence to give you the fiber optic, and hopefully you can do some training on one of those mannequins as well. Anyway, so the local anesthetic plan, firstly, the max dose is really important. So there's a lot of numbers that have been bandied around. This is not the max dose for a subcut injection. It's the max dose for kind of aerosolization and topicalization of stuff. So it's 9 milligrams per kilogram, which means a lot of people would use 4% because you just need it to be a bit more efficacious than 1 or 2%. That's like 15 mils of 4% or 30 mils of 2%. So generally I'd use the 4% for topicalization. This, I'd use an atomizer, it used to be called a De Vilbius atomizer, which was a reusable thing. It's just very hard for CSSD, the sterilization part of theater, to clean and sterilize it. So these days you've got this easy spray. Now, if you can see my arrow there, this is a chamber and this is a cap that screws off. So you literally fill this with local anesthetic, and I'd put 10 mils in there of 4%. You don't end up using all of it because this the little pipe here doesn't go all the way down to the bottom. So you end up using 8 mils of 4%. oxygen attaches to this device here, and then you just turn it on to 4 liters, 6 liters, and you press this device and forward, and that then causes the oxygen to flow, aerosolizing these particles. And then this nib here, you can rotate up and down. So initially you aim straight back, and as the patient gets more anesthetized, you can put this device further in and then aim it downwards. So it's aimed towards the larynx. Literally, I'll get patients to breathe in, inject, breathe out, stop injecting, and you'll see a mist coming out. And that's a good sign that they're inhaling it into their lungs and all through their larynx. It's not very pleasant, so I often have to hold the tongue out. And the best way to hold the tongue, because it's so slippery, is with gauze. So I get them to poke the tongue out. It's a lot of coaching, and just this takes a minute or two just to get everything in. The patient's ready. So when the patient's voice has changed and they tolerate either you pushing the Vilbis nib at the back of the throat, if they tolerate that, they're probably ready. The voice has changed, they're ready. And this over-sapien airway, so if I put a Guedel or if I'm doing an oral route and I put this airway here into the back of the throat, it'll probably, and they can tolerate it, that's probably fine. This is actually a Berman airway. It's not my favorite. The over-sapien is a kind of a wider airway that has a less sharp angle, which I'm a big fan of. That just, it allows the fiber optic to go through. It's like a Guedel with a large aperture. You can put the fiber optic and the tube through that, and it stops the patient biting down, protects the tube, protects the fiber optic scope, as well as creating a bit of an aperture to your larynx. I always keep a spare 2 mils of 2% lignocaine in a couple of 5 mil syringes. So when you get your fiber optic scope down to the trachea, you can see the trachea, and you might squirt over the trachea to just numb that area really well. The patient will cough, and it'll be a bit unpleasant for them, but at least it's really numb. And sometimes I'll go, once I've gone inside the trachea, I'll do that again just to really numb the whole trachea. You don't always have to do that with really good atomizing. You can just see how well the patient tolerates it. Okay, so there's many ways of doing this, but any questions about that or anything else you've seen? The procedure really is you get the patient to open their mouth, or the one nostril that you've prepped with cofenilcaine and the atomizer. You guide the tube through the cords. Often what you see is as soon as you put the scope in, it'll be just pink everywhere, just soft tissue everywhere. So the most incredible maneuver that I've ever learned in this is just to do a simple jaw thrust or hold the tongue with gauze and pull it out. And suddenly that whole inferior oropharyngeal area just opens up, and you can often just see the cords right there. You spray the cords like we mentioned, you go through the cords, and then importantly, you go down to the carina, and then you go back about 4 centimeters. So you know exactly how, where this thing, where the tube is going to sit, at the carina. And then, knowing that the average distance of your cords to your carina is about 12.7 centimeters according to one study with that standard deviation. So, you know that 4 centimeters is going to be far enough above the carina that's not going to go endobronchial, but also it's well enough that it's not going to come out. So just knowing that information is important. There's a lot of these things on YouTube of people who've just done fiber optics. So I really encourage you to watch the actual technique. The actual technique is far easier than the preparation, topicalization, and sedation. That is actually the hardest part for most people, I'd say. Now, here's the most important thing. The only way you fail this procedure is this. The patient ceases ventilation, and then that means that you potentially have an impossible airway that you need to do a surgical airway for. So the one rule about awake fiber optics or awake techniques is you must see end-tidal CO2 confirmed prior to any kind of heavy hypnotic or muscle relaxant or high-dose opioids. So before you give propofol, muscle relaxant or high-dose opioids, you always check that you've got end-tidal CO2, and you're not allowed to give it unless that. So the thing that you'll see time and time again is the patient just isn't prepped well. The patient isn't tolerating it. They're feeling a lot of pain or anxiety or whatever it is. If that happens, you just have to redo. You start again. You don't just go forth with the patient coughing and bucking and being anxious about it. You redo the whole anesthetic. And if that means that you've gone past your maximum dose of local anesthetic, so be it. You have to, if it's an elective procedure, you have to do it another time when they're safe again. Otherwise, you risk local anesthetic toxicity. Any questions about, so that's awake fiberoptic in 6 steps. Okay, so the last 2 cases before we finish up is a bronchopleural fistula and a traumatic laryngeal fracture. Now, bronchopleural fistula, has anyone seen one of these or had this as a case? So it's often, you know, let's say in the kind of the quaternary hospital context, you might have a pneumonectomy and then you have breakdown of the surgical stump. So now you've got opening. So you've got this fistula out into the chest. So how do you induce this patient? Now, I want you to think about your priorities and what it means to have, you know, a hole in one of the lungs. That's probably a bit unfair to ask you this. Does anyone want to have a go at this? Because it's a completely advanced topic.
So I guess the one, I'll have a shot and you can tell me where I go wrong. So I guess in terms of our priorities here, I want to make sure the patient's oxygenated, and now we've got a connection between the pleura and the atmosphere. So all we're worried about here is causing a really bad pneumothorax, which could be potentially life-threatening, and also soiling the good lung if there's any infection or anything like that that's sort of led to this.
Beautiful. I'm going to stop you there now. So that's exactly right. So these patients will often have a chest drain in, or if they don't, let's say it's a traumatic fistula of some sort, you need to put a chest drain in, and you definitely can't have it on clamp, because if you start doing positive pressure ventilation, it will, you know, cause a tension pneumothorax. So that's correct. Now, yeah, keep going.
Yeah, so I guess in terms of the procedure here, what you want to do is you're going to need a double lumen tube, because you're going to have to block off one airway and you've got to ventilate the good lung. So you've got to think about positioning and how you're going to perform it. So it may be that you have to do an awake double lumen tube, which is not something I have a lot of, I've actually got no experience with, but I think that would probably be one of the more appropriate procedures to do for this. So you have to think about positioning, equipment, local anesthetic sprays, and then a bit of light sedation to sort of get the process going.
Hey, so now I've made this a bit easier because I've said there's a pneumonectomy, but because essentially you just need one lumen tube down the correct side. But let's say you would be absolutely right. If you had a bronchopleural fistula and 2 lungs, then you definitely need a double lumen tube or some kind of one lung ventilation strategy, because if you were to positive pressure ventilate both lungs, the air will go down the path of least resistance, and that's always going to be the fistula side. So here's the inherent problem. The way you induce, so everything you said was correct. There's often a sick patient, oxygenation, you might be running aramine or noradrenaline because they're so unwell with some infection or whatever else it is, but you essentially have to maintain spont vent prior to isolating the lungs. Now, the reason for that, if you're spont venting, both lungs are going to be ventilated. You've got one that's not working, but at least the diaphragm is causing negative pressure to ventilate allow ventilation oxidation of a goodish lung. As soon as a normal induction, you paralyze, and then you start, and you give the induction aid, and you start positive pressure ventilation, which means you're pressurizing the path of least resistance. Therefore, your induction, ideally, the fact that, so spont vent is the traditional induction, but absolutely, if you need to put a double lumen tube, if you have got a patient that won't tolerate a spont vent induction, it could be because they've got a really difficult bag mask, they're obese, lots of obstructive kind of stuff there, so it just won't work. You will have to do some kind of awake technique, which may be awake single lumen tube, push down the correct side, or single lumen with a bronchial blocker, or a double lumen. And again, all of this is difficult. Nothing's ideal, but I want you guys to know that the priority is maintain spont vent prior to isolating the lungs. And then you deal with the journey. The method is up to you and your consultant, but this is terrible, but that's your priority there. If you're ventilating with positive pressure and it's all going down the other side, it is just horrendous. That's just an example of a double lumen tube. And, imagine there's a leak here. You really want to have this double lumen tube. And if no one's seen it, it's got two lumens, one which sits in the trachea just here, and the other one goes down one of the bronchi. There's a cuff here, which is a tracheal cuff, and a bronchial cuff. So it has the ability to ventilate one or each of these as well as both of them. Hey, any questions about bronchopleural fistula?
So would you send any positive pressure ventilation down the fistula side, or you just wait till, like, I'm just trying to wrap my head around the double lumen part, but like, where would you send a positive pressure ventilation on either side there, or is it just completely avoided?
You completely avoid the broken side. And because the operation that's going to happen is on the fistula side, they'll never want it ventilated. So you'd go straight in, get the tube fixated to the right point, which is the whole thing, and then you just ventilate down the good side, and just wait it out. After they've fixed it, then there's a whole procedure of slowly inflating both lungs, and that becomes the whole thing. For the induction, however, this is a priority. Final case. So traumatic laryngeal fracture. So 22-year-old male headed for theatre with a traumatic laryngeal fracture. How do you manage this airway? So again, just have to think about it. Maybe someone's seen this. Does anyone think about, just like before, there's many ways of doing this, but there's an inherent priority that you need to focus on no matter what method you take. There's a laceration somewhere in the area, laryngeal or tracheal. How do you need to do this induction? Think about it, and anyone can jump in.
Could I have a go over here?
Yeah, go for it.
So I guess the priority is not to make the trauma worse. Mm-hmm. So if he's got a laryngeal fracture, it's to try and keep the head as stable as possible. So when you are doing this, you will be considering doing a manual inline stabilization when you do induce and intubate this patient.
Actually, let's say that the neck is fine, it's being cleared. So manual inline, don't worry too much about that. I can see why you said that, though. Let's say movement of the trachea will be worse for it. Okay, keep going.
I guess the anatomy, when you do look in, would potentially be altered because of the fracture.
Yes. What's the risk of having altered? You've got a lesion, say in the trachea or the larynx. What's the problem when you start ventilating? You're suddenly putting positive pressure ventilation, and you've got a laceration somewhere.
Could you make your views worse because of that positive pressure ventilation?
Yeah, and it would make the view worse. So what happens is there's a chance that positive pressure ventilation will cause air to go through the defect and start causing massive subcutaneous emphysema all around the larynx and all around the neck, which will then inherently make everything worse, plus potentially traumatize, potentially make it difficult to ventilate. So just like the last case, if you've got a hole somewhere that you don't want a hole, you've got to bypass it and seal it off, and then you can start positive pressure ventilation. So again, that's the whole priority. You need to do it somehow. So there's a whole framework for this. Again, better you know it now. So priority, bypass the injured region prior to PPV. And so your induction is either one of the most difficult things ever, fortunately for the surgeon, not for you, but an awake tracheostomy, where you're there holding hands of the patient, giving them a tiny bit of fentanyl and sedation. The surgeon does local anesthetic around where they need to do it, and then do an awake tracheostomy. So you're not even giving any real induction, or you do an awake fiberoptic where you find, you go through as appropriate, just like we did before, and then you go past the lesion, and often they'll have a CT scan maybe, or a visible lesion, so you know where and how far to go past, and then you inflate the cuff and start positive pressure ventilation. So those are kind of the ideal methods, and there's a whole trauma kind of guideline to this. So if you've got, what we were talking about really was the stable patient, local anesthetic, tracheostomy, or awake fiberoptic. But then the unstable patient, you don't have time for a very, measured kind of practiced tracheostomy. So you may have to just, like, let's say the patient is suddenly becoming hypoxemic and unable to ventilate and the sats are dropping, you need to sort something out. So you may just have to do your rapid sequence induction and put that tube far down to make sure it's, down to the corona or even down one bronchus, and then retrospectively use a fiberoptic scope to bring it back. But again, make sure it's past the lesion. Let's say that fails, bad airway, bad whatever, lots of gunk around the mouth, too much blood. Then I need to just cut the neck again, cricothyroidotomy, scalpel bougie technique, which is kind of probably the best technique in this situation. And then again, get a tube down to the corona, past the lesion. If the lesion is on view, you may just have to use the lesion itself as your aperture down to the trachea. Again, you can always check afterwards with a fiber optic. None of that's ideal, but if they're unstable, you don't have time for a 10-minute fiber optic or a 20-minute fiber optic. Again, high-end stuff, it's better that you just know that these are priorities in these advanced cases now, because they'll come up once you're working in these various hospitals over time. Any questions, guys? Okay, so just a quick summary. So we went through the wake fiber optic and the whole preparation for that, and a couple of advanced things, which are really a bronchopleural fistula, laryngeal fracture. If you know your priorities, you can get to that, depending on what the complexities are around the issue. And yeah, thanks guys. That's all I really wanted to cover with you for critical inductions. Obviously hope that you don't get too many of these, but you will definitely see some. Being prepared, understanding the priorities will really help you understand this.